So for our first question, it's about population demographics. What is the demographic profile of the homeless population that you serve at your facility? And you can feel free to come off mute or place your answer in the chat.
Hi, Chad and everyone. I work at a smaller FQHC in Northern Nevada, and quite honestly, we have not done a good job collecting our social drivers of health or really looking at our population. That's how come I joined today, was to look at some best practices that are out there. So beyond, even at my old practice, a lot of what we received, I guess I did look at the basic demographics, but really what the needs were, I got through our outreach workers telling me what they were seeing the needs of. And then, so not more a narrative versus data driven. And
Mhm.
then here, quite frankly, quite honestly, we're not really looking at it that deeply. We're not even collecting. We collect someone's housing status when they first um, enroll with us as a patient, but
Mhm.
then after that, we don't update it. So even looking into the demographics, we're not there yet,
Okay. So you're
which
saying
is
that
which is
you're
part of the problem. And
yeah.
how come I'm here?
Okay, that makes sense. So I'm hoping that there are others on the call who have had some success with collecting demographic data on their patients, and hopefully they will be able to share their best practices with you.
Nice. What's it from community medical centers? And we are a fairly large FQHC. We see a variety of demographics of patients in our from our homeless population. So we have several clinics. We have one clinic that really focuses, that kind of is centered in kind of the heart of of a specific neighborhood where there's a large homeless population. We also have we have a behavioral health team that has we have mobile behavioral health van, as well as uh, we have mobile medical vans that not only, so patients, we can not only see them at our physical clinic, but we have vans that we go out into the community and provide dental, medical, and behavioral health services for. So we see families, we see patients with with some mental health concerns, veterans. We just have a pretty large demographic of patients that we see.
Okay, that's nice. Does anyone else want to share? Okay, I go to our next question. So our next question is related to access to healthcare. How do individuals access healthcare services at your facility? And again, you can feel free to come up chat, or you can place your answer in the chat. And as a secondary question, are there any barriers to healthcare access that you have identified? Such as transportation or anything like that, which is a really big barrier, and insurance as well.
Hi, Chad. My name's Aurelia Bradley. I'm with Circle the City here in Phoenix, Arizona. And individuals can access healthcare services in a variety of ways. Here at Circle the City, we have 5 mobile medical units that go out to fixed locations to work with patients that maybe don't want to come into our 2 fixed site clinics. So we have 2 fixed site clinics, 2 respite centers, 5 mobile medical units, and 3 street medicine teams. Transportation is definitely a barrier. And so our model, we've worked to expand the way that we're delivering care so that we can truly meet patients where they're at.
Nice. That is very good.
Thanks again. At CMC, we're in Solano and San Joaquin County, with the majority of our sites being in San Joaquin County. But we too, similar to Aurelia, I'm sorry, I'm basing your name incorrectly, but similar to her site, we have mobile vans as well, and we have 2 respite sites also. We try to our physical location that focuses mostly on our homeless population is kind of centered in an area that it's easier for them to access. Transportation is a concern, and then just kind of being able to, even though we're centralized in this space and we have mobiles, there's always a challenge of being able to, like, get to see patients regularly, because they can potentially hard to locate. But we have, and we see all patients regardless of insurance or ability to pay.
Great. Yeah, the biggest barrier that we've seen tends to be transportation. So it's great that you all have the mobile vans to be able to reach out to your community. Does anyone else have anything to share?
One of our barriers, so you can access healthcare services. We have 2 brick and mortar sites. One of them we just opened up that's co-located where our shelter is. And that site does allow walk-ins, but before that we didn't allow walk-ins as new patients. Even established patients, they had to use the same day appointment style. And we've been changing that and opening it up. I think one of the biggest barriers, aside from excuse me, transportation, is reputation, rapport, and trust. So since we've changed and opened up and allow walk-ins now, I don't think people realize that. We also had the way that we would accept new patients, you had to call at 8 o'clock in the morning to get an appointment the same day. And we have a more standard practice now to call and make an appointment that the population isn't aware of. And then just even though we're co-located, right there, it's building up, it's letting people know about the services and then building up the trust and rapport and showing them how to, it's safe to come through the front doors.
Yeah, trust is definitely a big thing. So I have a follow-up question. You said that they can call and make an appointment. Are they able to make appointments in person as well? Or is it so I feel that maybe some may not be able to call and have access to maybe a phone. So I'm wondering if they can walk in and um, schedule an
Yeah,
appointment that way as well. Okay,
yeah, they can do that.
great.
But just even finding, even just finding us and walking through the doors is
Yeah,
a challenge.
yeah, I agree. That's great. Does anyone else have anything to share? All right, I'm gonna move on to our next question. So now we're going to get into the data. What types of data are currently collected at your facility, and how is patient data managed, and what privacy and security measures are in place at your facility for that data? And I guess
Well,
I would feel like the biggest maybe not most important, but a very important data metric would be housing status. So, does anyone have anything to share about that?
So this is Aurelia again, Circle the City. We are an federally qualified health center.
Mhm.
And so we have a special population grant for people experiencing homelessness. So we have to capture all the required demographic information that HRSA asks for. So we ask for name, gender, sexual orientation, housing status, veteran status, migratory worker status, race, ethnicity, all of that information we collect through a digital check-in platform that's connected to our EHR.
Nice.
As far as privacy and security, that falls more into, I think our IT realm, but we definitely have policies and procedures around privacy and security of patient data.
Nice.
So that's kind of what we're collecting as a result of the UDS report, the Uniform Data Systems report that we would provide annually to HRSA.
Has it been difficult for you all to collect complete data from patients?
Yeah. We also collect social drivers of health or social determinants of health as well.
Yeah,
I know that for us, one of the barriers that we run into, specifically around SOGI data, so the sexual orientation and gender identity, is that patients don't always want to disclose their sexual orientation and gender identity because they may be at a clinic that's connected to, say, the shelter or the congregate care setting. And so sometimes there is some hesitation from our patients to collect that type of information. We had a lot more difficulty collecting the information when it was person driven. So when our front desk was giving packets of paper, patients didn't always want to or have the ability to fill out the paper packets. Since we've moved to the digital check-in platform, we actually have cleaner data as well as more robust data because it's patient driven, and so the patients are able to input the information in a manner that feels comfortable for them.
That's great. Yeah, I can only imagine how hard it would be to collect patient data using paper copies of those forms. So that going digital is actually really, really good. Would anyone else like to come up with me and share how data is collected at your facility? All right, I'm gonna move to the next question. So are there any existing health equity initiatives in place at your facility? And what efforts are being made to address health disparities within the homeless population in your community?
We do a lot with our gender affirming care,
Nice.
as far as health equity and being a safe place to come and get care. I am really excited. We're starting a project with the Huntsman Cancer Institute out of Utah that's going to help us with collecting the social drivers of health. So, particularly, housing situation, since that isn't, something static, it changes and people's needs changes. So, I'm really looking forward to see how we can start dynamically collecting the information to meet the needs of the patients, and then also determining where we need to put our resources.
Right. That's great. Right, so I'm just gonna go ahead and move on to the next one. Aurelia, you mentioned social determinants of health, so I do have a question about that. How are social determinants of health considered in the delivery of healthcare services, and are there partnerships with social service organizations to address non-medical factors impacting health? And I know, Ellen, you mentioned your collaboration, so that was great.
Yeah, so we focus, again, with HRSA requirements, we're more interested, we collect all the social determinants of health, but we're really focused on referring folks for food insecurity, transportation assistance, obviously housing status, and my apologies, I can't think of the other one that our teams are focused on right now. We do partner with community organizations because we are a healthcare organization. We're really focused on providing the medical services. One of our larger clinics and one of our respite centers is actually located on what's called the Keys to Change campus here in Phoenix. And it's actually a collaborative location where lots of different organizations have space and are able to assist patients. So we're really focused on the medical needs of our patients, and then we tend to partner with those collaborating agencies for the other drivers of health.
That's very good.
At CMC, we too are collecting social determinants of health data. We're currently doing a pilot, a PDSA kind of pilot program on a tool on a screening tool that we are that's called a pictogram. And so it's really just kind of in patient's initial visit, kind of getting them. It's really simple. It's a couple. It outlines some specific social determinants of health factors and allows a patient to just kind of when they're in their intake or their walk back with the MA to see a provider, just kind of circling, if you have a food insecurity, what's your issue with homelessness or other social determinant factors. And so the MA takes that information and then they are it's shared with the provider, and then we refer them to our case management department. So then case management sees the patient and kind of works up a treatment plan to help them with the specific needs that they've identified, and they go through like the prepare tool, to get more in detailed information about the patient, and then we partner with community-based organizations to kind of help them. So this initial screening tool helps us like address really specifically what what they feel their biggest concerns are, and then we go through with the prepare tool to help them to put together a kind of in-depth kind of treatment plan, and we follow up with or with the organization we collaborate with in terms of how they're progressing. That our case management kind of follows that trail and follows up with a patient to see if they've been able to keep the appointments that they've made with the other organizations, and how that's going and how that ties in with their clinical needs.
That's really great. Do you all ever deal with pushback from patients when it comes to answering those questions?
Um, we just got started, and so not really. I can't say that that's been a big thing. They're obviously we offer them the screening tool, and they can decline it,
Okay.
or they can say, that they don't have any, at there anything it isn't anything specific at the moment. So we like document all that, so we know that like a patient, that was offered to the patient, this is where they were at this particular visit, and then we just we have a we should try to look at that at least offering that to them like twice a year. And then if they do identify something, then we're like working with them on a regular basis. And so they at any time can like share more information, or or if their situation changes, then we're in constant kind of communication with them in order to be able to like address new needs as they arise, and then try to navigate them to where they need to be. But so far, not really any pushback. I mean, some patients they're not I would say they're not like offended by it or upset by it. They just, they may say, no, I don't have anything at this time, or I'd rather not share. But for the most part, the majority of our patients are, if they have a need, then they are absolutely identifying that and then, accepting of the services, and they're encouraged to like, move forward with like whatever services we can provide for them.
Okay, that's great. Does anyone else have anything to share?
But I just want to say too, we did have someone else had commented about problems collecting like kind of the SOGI data. And we've had a few instances where that was like a concern. So we've really been looking at this past year, kind of looking at our intake, the questions that are asked on the intake and how we can how we can ask those questions better. In order to make sure that patients feel comfortable doing that. We too our site that's predominantly in like homeless community is also attached to a mission shelter. But we have we have like 30 clinics, and so patients don't have to just to go there, but we
Mhm.
kind of we have other sites that if they're closer to they can always go to also. But we that's the only thing we've kind of had a little bit of issue with collecting that data, and for the similar reasons as Areli said too, that because they're attached to the shelters, it can be a little problematic for them. But we are looking at how can we ask those questions better so they feel comfortable.
Okay. Cricket, I see you have your hand up.
Yeah, we struggle asking the SOGI questions to some of our immigrant non not primarily English speaking patients. People can get sort of offended by that question or confused by it. And so I would love to, learn from anyone else who's dealt with that.
So one thing I will offer is that when we started using the digital check-in platform and patients were able to answer all of these questions um, independently and in some ways privately, we did start to see an increase in some of that more sensitive data. I think that also staff training around those questions has also started to help increase our patients' trust in us and ability to want to disclose that information. I think that when it comes to social determinants of health, there's sometimes is a perception that our patients don't want to answer these questions or that we get pushback just for asking those questions. And that's not been my experience or what I've observed. What I see with our patients is that they don't mind answering these questions, but they're frustrated when they answer the questions and we can't provide resources um, that might best fit what they need. An example of this is here in Maricopa County, most of the shelters are, male or female. And so where does that leave us when we have a situation where a patient might identify as non-binary or transgender? We don't have we don't have a shelter that's specifically targeted to that population. The same thing when it comes to like food resources. Sometimes we'll refer patients and then we'll find out from them the food resources weren't helpful because they don't have a way to store it. So there's lots of layers, and it's not always with the patients not wanting to give the information, but more so how do we receive the information and then what do we do with it?
Thank you.
Yeah, that was really good. That was great. Does anyone else have anything for this question? on to the next. So, more about data analytics. So, to what extent is data analytics currently used for decision making? And are there any challenges or opportunities for leveraging technology to improve care delivery at your facility?
So our EMR, we have eClinical Works, and it is horrible to pull data out of. You know, even clinical, we haven't made it to the SDOHs yet, even just clinical demographics and what we need to be focusing on. Um, so that's a huge challenge. We've partnered with our PCA to start using Azara as a population health tool, and I have high hopes and high expectations that we'll be able to get um, more population health information, and then be able to look and use those to improve our healthcare delivery and determine again what our population's needs are. And with that, looking forward to our project too, to how we can dynamically capture those social determinants of health. I mean, we have a transportation program, but is that what people really need? We don't know. It's just something nice that we do.
Right. That's really good. Just how recent have you all started using Azara?
It's not fully rolled out yet.
Okay.
So it should be completed by, have a more robust system by the end of the year. We did a lot. We had to clean up our data and get that aligned. And then our one business intelligence guy has been out on family leave.
Okay.
So hopefully we'll have that more robust and then looking at using it to submit our UDS this year.
Okay.
It's
That
kind
sounds
of
good.
the first phase one.
Yeah. Aurelia, I see you have your hand up.
Yes, Azara will change your life. So we use Athena as our EHR here, but we also struggled with being able to get to population health data just strictly within what Athena was able to do. We've been using Azara for probably almost 7 years now. All of my reporting comes from Azara. It's a much easier to use reporting data analytics system. We actually were in one of the cohorts for 2023 that submitted our data, UDS data using Azara. So if you implement correctly, if you stay on top of your data hygiene, work with your implementation team, Azara can help you to be more data driven. I'd like to believe here at Circle the City that we are really data driven. We use reports to, kind of analyze what is successful and what is not. But I think one of the biggest challenges that we have that's not unique to us is simply the interoperability of technology. And so, there are systems that don't talk to each other. We're fortunate in Arizona to have a statewide HIE, but not all healthcare organizations participate. So, data analytics, very important here at Circle the City. We do use Azara, the population health tool, to drive that. And our challenges or opportunities would just be more interoperability within healthcare systems locally and nationally.
That's great. Do you all have like positions there at your facility where people can focus more on the data analytics?
No, I'm a quality and population health department of one.
Okay. Oh,
So I make my tools work for me to help inform our organization. I mean, we have a couple of care coordination nurses, our providers all use these tools, but as far as analytics, population health, that's just me.
Okay.
Yeah, same here. And even as far as having IT support, we have one business intelligence guy who runs all the reports and is overseeing the Zara implementation. And we have one EMR specialist who's responsible for all things ECW.
Okay. Wow.
We do have an EHR specialist as well at this point. I used to also do EHR, but we do have a health informatics analyst, but really what he does is the EHR.
Okay. That's really good. I've never had the experience myself with Azara, but I have heard great things about it. So I'm happy that more facilities are beginning to use it. Does anyone else have anything they would like to share? All right. So a few of you mentioned your community engagement, but I do have a question related to it. How do you engage with the homeless community to understand their needs and preferences, and are there feedback mechanisms in place to gather this information?
I can speak to my old practice. You know, we had our consumer advisory board for patients experiencing homelessness, and we would meet, I think, every other month um, to determine, you know, what was going well and what wasn't going so well. They were also, sorry, reflecting a little bit. They were also great in sharing the information about our program and about us as a resource. Um, Currently, I'm not aware. I know we have a cab for HIV, um, but I really need to go back and find out if we're using if we have a formal process in place or if it's just what the case managers are getting from people that are referred to them.
So do you all ever collect like feedback from the patients themselves, maybe via survey or anything like that?
No, not systematically. We do a patient satisfaction survey,
Okay.
um, but not. It's pretty basic. You know, the way I look at things is about the intent, right?
Mhm.
So I think about looking at, you know, people experiencing homelessness and how are we meeting their needs and what else could we do better versus the letter of the law and kind of checking off that yes, we have a patient's experience survey that I think is done by phone after a visit, and it's checking off, you know, if the front desk was nice, if the provider was nice. Not really, are we meeting your needs? What can we do better?
Okay. Does anyone else use patient satisfaction surveys at your facility?
So I kind of put this in the chat. We use a patient satisfaction survey with additional questions for our respite centers. So it's a standard survey regarding patient experience. And then we have a couple additional questions that apply to the respite centers. We also have a consumer advisory board, and then we conduct quarterly focus groups. All of that information then is funneled up through our quality and risk management committee and then funneled up to our board. But the patient satisfaction surveys we find to be, again, I think like was kind of mentioned, to be more of a check the box. We are gathering patient information, but we don't get the bulk of what patients' experience is or where they genuinely have feedback from the surveys. We typically see that in our consumer advisory board or coming out of our focus groups. We also finally have a consumer board member. And so that has also brought the patient experience and feedback up to our board level as well.
Nice. So I have a question about the focus groups. I'm assuming they're made up of patients, correct?
Yes, they're conducted by our project manager. And they are quarterly moved through varying locations to capture different patients. And so like one quarter they might be in a respite center, another quarter they might be in one of our family health centers, and another quarter they might be at a consumer partnering agency to capture that outreach feedback. So yes, it's patients.
How are the focus group members selected?
So we offer them, typically we will partner the focus group with a meal. And so we will, encourage folks to give their feedback. We have some patients that really like to give feedback, and so they'll kind of ask to participate in a focus group. But for the most part, we advertise it as an opportunity to give feedback and get a meal.
Okay. That's good.
We too have patient relations and a feedback data that we share. Actually, our patients are able to like respond back in our patient relation in a survey or form, and then we share that information at our center leadership meetings monthly. So that data is pulled, and then the center leadership teams are able to discuss the feedback, and then ways to kind of address those issues, and to really look at what we're doing, what from the patient's perspective, what's going well and what isn't. So we look at that, we get that information, and we review that monthly. And we just started we just have I think we had our first kind of focus group with a patient, the patient advisory board. So we're just starting that, where it's its pilot phase. So it'll be interesting to see how that what feedback we get from patients regarding that. But that's something new we just started. But we do monthly address the data that comes in regarding our patient relations, and we use NRC as our the organization that kind of has a platform that collects that data for us.
Okay, that's good. It's great that you all are collecting that feedback directly from the patients. Okay, I'm going to move on to the next question. And a few of you mentioned collaborating with organizations, but are there collaborations with other healthcare providing government agencies or nonprofit organizations? And how do these collaborations contribute to the overall well-being of the homeless population in your community?
We have, the collaboration and understanding that, our clinic, we chose that spot to help the sheltered population. So it's there. We also work closely with our MCOs, because in the interim, all of the county came up with some different on-site healthcare, you know, mobile healthcare services. So we do collaborate with them. We also have a state Medicaid worker at, actually not our clinic that's co-located, but the other clinic that is further away that's there, and a great collaboration with her. She's incredible, and really meets our patients at where they're at. At the CARES campus, they have their own state worker there, which is how come I don't think I think they would consider it duplication, but we might have a better uptake, and just expanding that. We have agreements with the food bank, Care Chest that provides medications and DMEs.
Nice.
Yeah, but it's a rather small network to what I'm used to back at my old project.
Well, it's something, so that's good.
Yeah, true, true. One thing we've done too, I guess, is with our at the CARES campus, there's also a safe camp that ended up being kind of a tiny home situation. And I know thinking about the well-being, of food, um, access. Um, Food access is very challenging at the main shelter, but at the tiny homes, they get all the snacks from the food bank and have a relationship that way. Um, we actually do have our own tiny home housing project that we have a community urban roots, urban farming collaboration there. And my registered, so they're growing their own fruits and vegetables. And
Right.
then our registered dietitian will go and work with people to see what's provided through the food bank, how to can and use the fruits and vegetables. And so really looking at nutrition from that point of view. When we opened up the new clinic, I took my team on a tour of the area to see what food was available basically at the gas stations, and seeing what's typically made available through the food banks and how someone staying at the shelter, how someone transitioning um, could could take advantage of those resources. In Nevada, you're not allowed to buy prepared food with your EBT cards.
Yeah, I think that's true for most places. Yeah. But thank you for that. Does anyone else have any collaborations you'd like to speak about? All right, I believe this is the last question, actually. Oh, no, one more. So Aurelia mentioned proper training for the staff at her facility, but I want to ask the rest of you all on the call, what training is provided to healthcare staff to address the unique needs of the homeless population? I know a big one would be being trained on how to approach a patient with the questions about social determinants of health. I do know a lot. I have heard a lot of stories about patients have pushing back when it comes to asking those types of questions.
We used to do cultural competency. We take advantage of what's available on the council's website. I also think trauma informed care, we were actually introduced to through Matt Bennett,
Mm,
that I think has the best program for frontline staff. Um, and then we also mental health first aid. I think that I think they need to change that, not to mental health first aid, but just how not to be a jerk.
yeah,
Um, Unfortunately, that's what we had at my San Diego practice. Here in Northern Nevada, it's been quite a challenge to find the resources, the expertise, and then also the funding.
yeah, could definitely understand that.
Having the sheriff's department to come in and talk about trauma informed care is not a best practice.
I can't say that I've ever heard of sheriff's department coming and speaking on that topic.
Yeah, yeah, yeah. We try. We
Yeah,
try.
that's new to me. And move on. We spoke about this, so we don't need to circle back. We did have a great conversation related to this, and we also had a great conversation related to barriers of care. So those were all the questions that I had, and I want to thank you all so much for answering these questions, whether in the chat or coming off of mute. Like I mentioned, this is a part of an ongoing effort to explore how we can harness the power of data to address health equity, and your answers would help us come up with a way to give you all resources. We're thinking about hosting, we hosted a webinar earlier this year in June. We're thinking about hosting another one in the coming years. So your feedback to these questions is greatly appreciated. So I really want to thank you all. And with that being said, that is the end of this listening session. I did have this scheduled for 1 hour, but I'm going to let you all have 11 minutes back. So again, thank you so much for attending.
Thank you.
You all have a great rest of your week.
Thank you.